Thank you for joining this AI Med live webinar. My name is Alexis May, Director of Content at AI Med, and I'm pleased to introduce our two excellent speakers today, Dr. Christoph Wald, Chair of Radiology at Lahey Hospital and Medical Centre, who also serves as Chair of the Commission on Informatics at the American College of Radiology, and Dr. Ben Panter, CEO of Blackford Analysis. Now, this session is very much a two-hander today, so I'm going to be disappearing into the background and letting Ben and Christoph get on with things. If you have any questions or comments during the session, please do feel free to post them in the appropriate area, and we will respond to as many as we have time for. That's it from me for now. I'm going to hand over to Ben, and as I said, disappear into the background. Ben.
Great, thanks, Alexis. Welcome everybody, and thank you to AI Med for giving us the opportunity to have this conversation. I guess, Christoph, let's get the ball rolling with an easy question. So perhaps you could share some of the ACR's attitudes on AI for us.
Great, I will do that, Ben, and great to chat with you, and welcome everybody to this webinar. It's a pleasure to be here. So just for background, since we may have an international audience here, the American College of Radiology is a membership organization which represents the radiology profession in the United States. Over 40,000 practicing radiologists are members of the ACR, which is the acronym I'm going to use forward for the organization. And the organization combines the participation of volunteer members like myself with professional staff to further the mission of the college. Now, inside the college, there is what's called the Commission on Informatics, which I happen to chair at the moment. And within the Commission of Informatics is the Data Science Institute. Now, we formed the Data Science Institute as a body to collaborate with radiology professionals, industry leaders, government agencies, patients, and other stakeholders to facilitate the development and implementation of artificial intelligence applications so that we can help radiology professionals provide improved medical care by using this technology. It became clear about 5-6 years ago that this was really going to take off, and this was sort of the college's response to systematize the effort of supporting the path for practicing members to use this technology. So we try to address a number of things. Some of what we've done is infrastructural. So we've built something that's called AI Lab, which is a platform that ultimately can help radiologists test, validate AI, try it out on their own data. We've worked on use cases to try and provide some guidance for industry, what represents clinically impactful and meaningful targets for AI development. We are working on developing standardized pathways for implementing AI in clinical practice. We're working on educational materials for practicing radiologists to really understand the benefits and also the shortcomings and the things that people need to watch out for when they first implement this kind of technology. We're working on approaches for monitoring effectiveness of AI algorithms in clinical practice. And I will emphasize that all of this is really works in progress, and we're by no means done. And then we're frequently talking and addressing regulatory, legal, ethical issues in the form of white papers. So we have the ability as a radiology association to gather up experts in the field. You're going to see a two-part white paper come out very soon on data sharing in medicine, considerations around that, and so on. So hopefully that gives you a bit of an overview as to how we're approaching this.
Absolutely, and I think from the industry side, I mean, we're delighted that the lead that the ACR is taking with the Data Science Institute, but also the kind of the wider activities of the ACR around reimbursement. I appreciate that's a different area to your specialization, but you know, all of these different places where the college is working in partnership with industry to really try and make sure that we get AI out into clinical use in a responsible and useful fashion. Mm-hmm. So the topic for this discussion is value for AI. And I thought it was interesting really just to step back from AI in specifically right now and just think about value for radiology, and you're the chair of a radiology department, how do you think about value overall? What's kind of shapes your thinking there?
Yeah, so two ways, sort of in a very much sort of keeping that answer to my very own institutional context here. I work at Lahey Clinic, which is an integrated group practice, which means all of us physicians and other caregivers here at our organization, actually employed by the organization, we're perfectly aligned, and it's a very collegial and collaborative environment. So it doesn't take terribly long for me to find out from my colleagues whether the work that we're doing here in radiology hits the mark or does not. And they're also very quick to point out opportunities and vice versa. So, you know, I consider myself very fortunate to be in that type of practice model where all of the subspecialties, including radiology, but also the other clinical specialties, are really under one roof, and there's very little impediment for constructive and collaborative work. I found it to be a very happy and good long-term practice environment. Now, taking a step back, if you have to extract the answer for value to a more sort of theoretical realm and apply it to other settings, there are many different organizing principles out there that one could use. The quadruple aim is sort of one that I think has originally been brought about by the Institute of Healthcare Improvement here in Cambridge, Massachusetts, but basically focuses on several dimensions: the patient experience. So in other words, how does your new approach impact that experience, if at all? How does it impact the work and work life and experience of the providers that are providing the care? Because clearly it's a two-way street. And does it actually impact, if you do what it is that you do to multiple people, can you make an impact to your population, whether that's the populations that you're serving, population of your patients in your environment? And then also, what happens to the overall cost of care? You know, if you're making a beneficial impact on your patients, you know, does that overall reduce the costs of healthcare, either in the individual care episode or over time? So that's just a framework to help you think through whether your new surgical approach, your use of AI, your new imaging modality really contributes to any or all of these aspects of care.
Sure, I think it's a really useful framework for assessing any kind of innovation, and I think it's helpful to try and go into, from the industry perspective, your customer's mindset and understand what's going through their mind. And I guess all of these different areas, I mean, things like reimbursement are almost meta statements for that quadruple aim, right? That a process is reimbursed because it's shown to have benefit to patient outcomes, and the payer has assessed the value of it and determined that it's acceptable. I'm not sure whether that takes into account the improving the life of the caregiver, though, and I guess sorry, the provider, the clinician that's giving that care. How does the kind of the work life of the radiologist or the referring clinician come into that context?
I could, you know, in many different ways, but I'll just pick a couple of examples specifically to AI, but also in other sort of development cycles that we've seen previously for production systems in radiology, meaning the types of software that we interface with as working radiology providers on a daily basis. Whether you take voice recognition systems, the user interfaces of PACS systems, and now increasingly of AI, there is definitely an opportunity for good ergonomic development for easy, intuitive interfaces, reducing clicks, driving efficiency. You know, that I remember many years ago, we used to manually have to type in the medical record number of the patient into multiple systems in order to then be able to do work that spans multiple systems. So if I have to look at the images in one system and dictate my report in another, you know, once upon a time, I had to activate the login differently into these systems, authenticate differently, put in the medical record number manually. Now that's all integrated by a workflow solution that is governing all of these applications that we're using. So that's one way in which technology development can and should take into account the user of that. Because as a human doing this work, I may have my talents, my experience that I can bring to bear on behalf of the patient, but if the work itself, how it's done, fatigues me so much that my ability to actually put proper diagnoses or discover subtle findings is impaired, then that's a real problem. So, solutions that we think are optimal are those that are well integrated with other production systems, that are easy and intuitive to use, but have taken into consideration the activities, clicking and so forth that need to occur, and that are ultimately then driving efficiency and a lessening fatigue of the clinical user. Now, from a clinician perspective, what would make their life easier? Well, if we hit in our reports and or the results that have come out of AI or other diagnostic system, if we hit the high points, if we provide them with information that they can then plug into their clinical decision making, in other words, by giving them relevant work product, we can drive their happiness and their sort of efficiency. Timely communication of these results, not just the content itself, but timely communication and making these results available at the point of care when they need it for their decision making goes a long way. And by extension, increasingly now we're making our own results, the images, available to patients directly. There's been a recent movement against information blocking in the United States, and there's now a widespread making available of information directly to patients and providers on a very short timeline. So those are ways in which we can impact efficiency and experience of providers and patients.
Sure, absolutely. And if we hone in on AI, I mean, obviously there's all sorts of different kinds of AI products that deliver in different ways. And I usually think about efficiencies within radiology, be that either the radiologist being able to produce a quicker report and saving time that way, or even just getting higher throughput through modalities so you can have more scans generated per hour, per day, whatever it is. Then you go down to kind of adding value beyond the radiology department, and thinking about improved outcomes, reducing overall costs, but really just giving the clinician, as you say, information that they can action, things that input into their clinical decision process and make a difference to the patient there. And then we have things like triage and elements like that of getting the right treatment to the patient quicker, moving them up or down a list. And then there's population health, and population health is really kind of hard to determine the value on a very short-term basis, but incredibly valuable in reducing the overall cost of care for a patient and patient outcomes. And I think, I don't know if I've covered the whole range of things there, but maybe if we go through them and just think about where the value is from your perspective, it would be really interesting to hear. So I kind of think that within radiology itself, it's fairly straightforward. Are there other things that I've missed there?
No, I think, Ben, that was a really good and complete overview. So when I try to talk about that, I basically try to remember the whole value chain of radiology, which is probably even a little bit earlier with ordering and scheduling. So I actually see tremendous opportunity for AI to help us optimize our scheduling system, drive automation, patient-driven automation, so that you can get to a level of user experience that people are used to from their consumer life. It is fairly straightforward to book an airline seat. It's still not so straightforward to get an MR booked. So even if you subtract layers of insurance approval and payment layers, still booking that resource by yourself as a consumer is not terribly easy. So I think there's opportunity there for more sophisticated self-serving systems. Also optimizing the match between what the patient needs and what resources we have available in the form of scanners and scan slots. So that's at the very beginning of the value chain. You could even go further up the chain and say, when clinicians order imaging tests, there's probably opportunity there to refine the decision support at order entry by, future better ability to digest known information about the patient and compare that against recommendations, what would be the best next step. So decision support at order entry, help with scheduling, I think there's opportunity for systems there. Then you've already alluded to image acquisition. So just to give a few specific examples, if you have the ability to reconstruct images from fewer pieces of information, you can, for instance, have less sampling in PET CTs or nuclear medicine exams. So you can really decrease the time of acquisition, which does a couple of things. The obvious one is you can put more patients on the schedule, which we have just put in a new scanner, and we're able to do that now. But also, let's not forget that if you can shorten the exam time of the PET, of the MR exam, it really is more comfortable for the patient. It's not fun to be flat on one of those hard couches in a scanner for 45 minutes. If you can get that down to 20 minutes, a lot better for the patient experience. In MRI, there are newer approaches of making images from just partial sampling of the case space. So again, a significant time savings there on the acquisition side, because you have to have less sampling of data. In CAT scanning, iterative reconstruction algorithms have benefited from advances in reconstruction technique. And you can do lower dose CT acquisitions because you can reconstruct images with iterative recon from lower data sets. So moving on to, once the images have been acquired, to the radiologist itself, I probably won't spend too much time talking about that opportunity there. You already mentioned some. It ranges from disease detection, so maybe making a task that was traditionally done by a radiologist, automate that, or make that more sensitive, or provide that belts and suspenders, second reader approach, where the radiologist can check, does the AI agree with me, and vice versa. Remember, AI doesn't tire, as radiologists do. So in the 11th hour, having that ovary might be very, very nice. We also have times in our practice where we have a limited workforce at night, on the weekends, whereas the ED is super busy. Sometimes the radiologist can get a little bit behind, and that's where triage can become very helpful. If a computer algorithm can reorder the work that you're going to have to do when you're behind, that really helps to get to the relevant cases first. Moving on now, sort of going to your population health measures. One of the things I'm most excited about is that there are emerging AI approaches that can often quantitatively characterize things that we capture on our imaging, but the imaging wasn't done for that reason. So muscle mass, fat, calcium in the coronaries, emphysema in the lungs, bone density in your vertebral bodies, that's usually not why we do an abdominal CT, for instance, but those things are all captured on the same examination. And so if you have technology that can not only assess these things, but also quantitate them, you can actually learn a lot about your patient. I want to draw your attention to a recent 2021 radiographics article by Perry Pickard and Ron Summers. They actually talk about this concept of opportunistic screening on abdominal CT. Opportunistic meaning it happened parallel to why you actually did the CT, but they're going through a whole range of automated body composition biomarkers that add a lot of cardiometabolic value in risk prediction, risk stratification for the patient, that may become very valuable for managing large populations of patients and determining who needs to have more intensive, let's say, cholesterol lowering treatments, or who needs other pulmonology exams we're ourselves, we've done recent investigation on our large lung screening data set and have found that there is a correlation between the presence of a certain severity of emphysema and hospital readmissions of these patients. And we're thinking about using that as a stratification tool to bring these patients that have a certain threshold, that exceed a certain threshold of emphysema, to a different way of treating them, more intense clinical visits to try and reduce readmissions. Then there are examples of interventions, surgical or minimally invasive interventions, that are now being tied increasingly to findings that are only able to be done with AI. So for instance, lung volume reduction, which can be done with surgery, or it can be done with placement of a pulmonary valve, so a little one-way valve in your airway, is only permissible or recommended here when a certain threshold of emphysema is exceeded. So we're actually going to, or we're already doing that analysis when a patient is undergoing consideration for this treatment. And if the quantitative result shows that a certain emphysema level is present, then we go ahead and place the valve. Radiologists are not able to do this work manually. This is computer-based work. We had semi-automated approaches that took a lot of radiologists' time to come to the same results, but that has now been automated increasingly with AI. And so that's an example for an AI result being the gatekeeper of a more invasive result. So hopefully I gave you some examples here at the very end of this value chain, how you can begin to put together multiple AIs or specific AIs to either be gatekeepers for different clinical treatment of these populations or in individual patients as gatekeepers for treatment.
So I guess that touches on the kind of the downstream value piece, right? Which I see there being massive potential for patient outcomes and ultimately for the long-term cost of care for the health system for that patient or that category of patients. And I'm the thing that I think we struggle with and our customers struggle with is if you've got that cost being incurred in radiology, but the benefit is accruing in pulmonology or neurology or wherever else, how do you square that circle? How does that all fit together?
Yeah, that's an age-old problem, certainly here in the United States, where the prevailing payment system, the reward for carrying out clinical care, is still very much transactional. So the reward is tied to the individual transaction of care. So you're speaking plainly to that, and this, we've seen a shift in payment models. The government payers as well as the commercial payers have recognized a long time ago that it's maybe not in the best interest of trying to keep costs reasonable to reward volume of healthcare transaction, and to really strive to find ways to reward outcomes and value that is given to patient, and ultimately the payer gets pays their dollar for the health of their customer, their insured patient. So I think we're somewhere in that journey. I think it's an aspirational goal. It's been it's tricky because healthcare is fragmented, healthcare delivery is fragmented, and oftentimes the contributions of the radiologist, of the initial primary care, the radiologist, and maybe the surgeon or someone else who does something and then it goes back to the primary care physician. It can be difficult to measure who contributes what to the ultimate outcome. I think the two big movements that we're seeing here that will help is, number one, proliferation of payment systems that take total cost of care over a longer period of time into consideration, and then basically true up with the healthcare provider organization at the end of the year or a year later and say, okay, we thought you should be spending this much, but you spent this much. And if it's less, we have models whereby we share the savings between the organization and the insurer. And if it's more, there can be pretty hefty penalties that provider organizations incur. So you can see there's a carrot and a stick motivation for healthcare organizations that operate under these circumstances to really begin to pay attention to how the individual care episodes play out. So these so-called accountable care organizations have staffs that do a lot of data analytics about, value contribution and outcomes, and try to influence either dial up or dial down interventions to these patients throughout the year to modify the cost value equation. I think the other,
sorry, go ahead.
Oh yeah, I was going to say the other thing that sort of has helped is there are organizations like Kaiser or Intermountain or Geisinger and so on, integrated organizations where the payer side and the provider side are sort of unified under one corporate umbrella. So if the provider side does something particularly well, let's say has great outcomes at low cost, then the benefit accrues on the insurer side. But since that's one corporation, you can then reinvest that money into better, provision of healthcare. If it accrues to separate organizations, that is very difficult to do. So that's sort of somewhat independent of the payment system, because if both the payer and the provider are under the same corporate umbrella, then even in the fee-for-service system, you can sort of build that fortuitous cycle.
And if you were to look at a more traditional setup, as I guess you have at Lahey, where there's a mixture of ACO type work and traditional reimbursement based work, is there, do you have visibility of that as a radiology department on a daily basis, or is it just you get a number at the end of the year and you have to work out how to improve it next year? How does that get visibility within a department?
We do get feedback on a regular basis. I also happen to serve on the board of the ACO, so I actually see the analytics. But there are very specific utilization numbers, and there are benchmarks. So we see the imaging utilization in our population, and you can see the benchmarks in similar organizations. There's some attempt to do risk stratification so that you somewhat compare apples to apples. We have a chief value officer here who meets with division chairs like myself and explores opportunities for efficiency. We review the results of decision-supported order entry. We see how our clinicians respond to feedback that they get on appropriate or inappropriate ordering. There's opportunity there to influence the ordering. If we see that there are patterns of certain professional groups, say, to pick on someone randomly, if the neurologists are seemingly over-ordering certain types of exams, let's say inpatient MRIs, we would then engage them in a conversation and explore, what's going on. Are these new colleagues that have moved into the organization that are not yet familiar with how we take care of people here? Or what's going on? Oftentimes, what I find is medical doctors, providers of any kind, really want to do the right thing. And when there's a drift in their behavior that's maybe not advantageous, oftentimes all you have to do is just show them what's going on. And, almost never do these things become controversial. It's usually pretty obvious what the right thing is to do. And when you show people data about what's happening, they oftentimes draw the right conclusions themselves. And so we use some of this information to manage behavior among our providers.
Sure. And I think when we come down to, you mentioned something earlier where reimbursement doesn't exist yet, and trying to think about how interested stakeholders can prime that pump. I recall that Lahey had great success with a very early lung screening program prior to that being reimbursed, and I think that's a great example. I wonder if you could take us through that.
Yeah, so that's a great thank you, Ben, for that lead. So let me take you through that. So in 2010, the national lung screening trial that had been conducted here in the US on about 56,000 patients for several years was halted. by the ethics board because there was such a profound mortality advantage in the CT arm versus the chest X-ray arm. These are high-risk patients, patients at high risk for lung cancer due to their smoking history. In the control group, they got the chest X-ray annually, and in the treatment group, they got a chest CT annually. And after 3 years, it was so obvious that the group that got the chest CT had a better outcome, minimum 20% mortality difference, that the trial was halted. So this is 2010. In 2011, the NCCN, which is a guideline producing body in the cancer space here in the US, made the recommendation that lung screening ought to be done on high-risk patients based on this result. Now, at that time, there's not a single program in the country that had done high-volume lung screening. I think the highest volume program at the time had done about 100 patients. We're talking about clinical programs now. They were offering lung screening at highly variable rates. Remember, screening is asymptomatic patients, so there's not a reason to do the exam other than the screening impetus. So the prices range from $100 to $1,000, no reimbursement to be had. We felt here that a 20% mortality benefit was not something that we would typically be able to achieve for our patients, and that irrespective of payment, we had to start doing this. Our management took some time to wrap their brains around the fact that we wanted to go ahead with this clinical service, even though there was no payment available. We were convinced that if we could reproduce or exceed the results of the trial in our clinical program, and if we could show that this could be done at reasonable cost, there would actually be payment. So we started the program in January 2012, started scanning patients, and within a couple of years, we were able to show on about 1,500 or so patients that we had scanned at that time that this was working beautifully. In fact, our results were even better than what was seen in the trial. We then helped inform CMS, the federal payment agency here in the US, the insurance agency, with our data and with our story and with, together with others, of course, that had started to do this, to make the case that this was actually working. It was saving lives. It wasn't terribly expensive to do. We had a very good handle on the program management itself and the tools and the time it took and the professionals that were required to be successful. And so ultimately, 4 or 5 years later, payment was established together with a lung screening registry, because CMS, the payers, wanted to also be sure that doing this on a large scale wouldn't open the floodgates on incidental findings with unnecessarily driving healthcare costs. So we had not seen that in our program, and so far I think that's not what's been seen nationally. So, sometimes it takes, this is probably a fairly characteristic period of time, 5 years, from using a new technology to having enough evidence for clinical benefit and understanding the cost of providing a service to then really make an argument for a payment code. So it just takes early adopters, people who are convinced that this is working to the benefit of patients, who are willing to adopt the technology at their own expense, to prove that something really works and iron out some of the implementation details and workflow details. And with that, sort of being pioneers and setting the stage for what is going to be future standard of care. So I could imagine that this could happen very well in this AI context. I think a lot of this AI in one form or another will be standard of care 10 years from now. And there will be payment for those approaches that show value.
And I guess for clinical leaders wanting to make their mark on the future, this is a great opportunity. There are so many different clinical use cases of AI in radiology, where the understanding is that, I'm sure this has some impact for patient outcomes and cost down the line, but we really need to refine that argument to work out the process to be able to go end to end. And then eventually reimbursement is kind of a lagging indicator, if you like, that you get the T code, you're able to track the usage of that process. You're then able to build the statistical argument as to why it's worth the payers investing in this. Then you go around every payer and you try and build it up. But I think the willingness of providers to get involved and to say, you know what, we put a small bit of investment in here, but we think that we could be really contributing to shaping the future of healthcare in this particular disease condition, and the use of AI within it. So I think the lung cancer screening example is fantastic because it really does demonstrate that a well thought out process to build the argument for something that really does look like it has clinical impact, and how to fund it centrally and how to build that argument together. I mean, if we were thinking about doing this for a given AI tool, and who knows what that would be, but let's think generically, how would you measure and track the value that was being created of such an AI product within a facility?
Yeah, so it starts, before we even get to the value piece, I think the first thing that an institution needs to do, and that we have done when we have considered the use of specific AI solutions, you have to make sure it works. So you need to be able to deploy it. Either you do that yourself, or maybe you have an arrangement with a platform vendor on which this can be activated. And then you have to make sure once it's deployed that it actually works with your data. You cannot simply assume that just because something is FDA cleared, it will work. And by no wrongdoing of the vendor, there is a limited amount of data on which any AI solution was trained. And if that data set is just too different from what exists in your own institution, there could be a difference based on the population, or it could be a difference on the instrumentation, the machines that produce the data that the AI sees, or a combination thereof. So if that's too different from what it was trained on, then you can probably not expect the same level of performance. And that has been shown in experiments when AI was taken from one to another institution. There are ways to then get it to perform better at your local institution. So there's this whole notion of acceptance testing, or validating that it works as intended on your own data. And that's really a workflow step that has never existed in radiology. And as a result, we don't really have that catered for in our production system. So I don't have a sandbox where I can try something out. I don't have a systematic data collection place in the PACS or in any other production system where I could review the last 500 or 1,000 cases I've done with a particular AI. So at this early stage of the game, those of us that have started to implement these systems had then to develop ways in collecting the data. So you end up having complex spreadsheets. Your radiologists need to remember to collect their impressions or their agreement or disagreement. If you have a workflow vendor, you may be able to talk them into creating a contextual way of capturing the outcome for each AI transaction, and then over time build in some confidence that things are working as intended or they're not. So we had to get a little bit creative there. So we did all of the above. If you want to then really look at outcomes, then it really depends on what outcome you're analyzing. So an easy one, or a relatively easy one to measure, was, in our case, what happened to our turnaround time for intracranial hemorrhage detection. It's usually very good because we have very good prioritization of these cases anyway. But as mentioned before, at nighttime when we have fewer people working, or at the weekends, or in routine outpatient exams that weren't actually done for this purpose in the first place, but the patient happens to have a hemorrhage, those are the cases or the times when the turnaround time could be significantly decreased. We've seen really significant decreases there in these edge cases. So that would be one outcome that is certainly beneficial. If you want to look for more complex downstream positive clinical outcomes, you're going to have to increasingly dig into the electronic health record, because remember, our imaging transaction occurs at a point in time, and then the observed improved outcome may actually not happen until 6 months later, 1 year later, a couple of years later. So for this reason, we're actually putting my ACR hat back on. We're going to spend some development cycles and some work on making the clinical information in the EHR more accessible to the platforms where also the pixel-based AI happens, and then power sort of hybrid approaches where you not only use the AI maybe to do an initial something, whatever it is that it does, but to then also combine that with clinical downstream information over time and sort of do pattern analysis across multiple patients. So we're going to have to unlock the information that slumbers in the EHR in order to get those proof points done.
Yeah, I think I can reflect on our experience building these kind of platforms that within radiology, everything is reasonably well defined, and given time and willing partners, you can pull all this information together and build systems that integrate into all the different steps of workflow to be able to aggregate this information and store it appropriately. Once you get out to the EMR, a simple HL7 or a FHIR connection is fine, but trying to actually get deeper information about what's going on with a patient rather than just trivial context that you can pull straight out becomes more and more complicated. And I think that there's a kind of, or certainly the approach we take is that we do as much as we can automatically, but we recognize that there's a human aspect as well, that working with our customers, our deployment sites, to be able to manually pull some of that information and supply resource to be able to do that is usually the most efficient way to track that kind of information over time. And that kind of, I guess, customer success is the kind of the broader term, but really being able to understand and probe that kind of information in the EMR is incredibly hard to do in an automated method.
Right.
But I think absolutely recognize that if you're looking at value of a tool for the referrer and for the patient outcomes and the population health piece, that's really where you have to get to.
Yeah, I think there's also a lot of opportunity there to help ourselves by standardizing more. So we're RSNA and ACR have joined together around the common data elements effort. So with about 1,000 or so common data elements now being defined and growing indefinitely, what we're trying to do is when we build systems that either provide radiologist decision support at the time of reporting, and when that results in specific disease labels or outputs, these are now being encoded in these common data elements or sort of tagged in the background or mapped to these common data elements, so that any sort of downstream analysis that will occur can be unambiguous, because you no longer just have to rely on the word that's in the report, but you also have the unique tag in the background. So I think the increasing use of RADLEX, SNOMED, common data elements, and so forth will over time drive out ambiguity. Now at the EHR level, there are certain other systems that are commonly used, LOINC codes, for instance. We're going to have to wade into this and figure out to what degree there is standardization or there's lack of standardization. I suspect it's the latter. I think for the most part, EHR companies have given a lot of latitude to their customers to customize their data fields and names and so forth at the local level. And I strongly suspect, I don't know this for a fact, that even if you take multiple instances of the same EHR across multiple institutions, that the data dictionaries are going to be slightly different. So you have variability in the naming of the data fields, possibly the content. And then on top of that, a lot of the medical information that is relevant is currently stored in unstructured human language that is simply transcribed into the EHR. And so that's the other big challenge, big frontier, is to really improve our natural language processing tools and their understanding of human language to, again, take the unstructured information in the EHR and structure it and standardize it so that computational systems can actually make sense of the content, and so that we can unlock the potential of this investment.
I think that it's interesting looking at proxies as well. Obviously, we do NLP on the radiology report, but that's a much easier challenge to solve than looking at the full EMR data and trying to abstract the particular piece of information you're looking for from there.
It's a much smaller language universe. I think radiology language has about 30,000 words, whereas this is a much bigger language universe if you go to the general dictionary.
Absolutely. And I think that the other piece that you mentioned was, before you're down measuring the detail downstream, it's how do you check that the AI works and not, maybe the wrong word, but not pollute the medical record with things that you may not, as a clinician, wish to have in that medical record.
Right.
How do you guys handle that?
Yeah, so we're particularly rigid about that. So I have not allowed any AI results of the algorithms that we currently have in clinical production to be sent to the PACS, which is essentially the imaging record of, the imaging record for the patient. We are currently viewing those results as radiologists in a separate viewer. In this case, because a lot of our algorithms come from a single vendor, the vendor has figured out how to expose these different results in one viewer. And so we take these under advisement. Our interaction with the AI result is in the viewer. The feedback, if it's a false positive, false negative, happens in the viewer or in the workflow system. I think there is significant opportunity and a need as the number of AI algorithms grows to have more sophisticated sort of final mile viewers for these diverse results so that we can inspect them and validate them and incorporate them into our interpretations. And then potentially, when it makes sense to release a result into the medical record, only do so after the imaging expert has sort of validated that it all checks out and makes sense. AI is brittle, AI can degrade over time, and it is absolutely necessary, in my opinion, especially for diagnostic AI, to have an imaging expert validate that what it shows, in fact, checks out. There are a lot of imaging artifacts that occur occasionally that can mimic disease. And as part of our long training as radiologists, typically 4 years of residency and 1 year of fellowship, to become familiar with these artifacts that look like disease. If these artifacts were not contained within the training sets that the algorithm saw, the algorithm surely will interpret them as disease, and that's what we're seeing in regular practice. It's not a problem because the radiologist can easily identify that it is an artifact, but if you were to just let the result flow through into the record, then that would not be easily recognized. It is quite challenging for good reasons to eliminate things from the permanent record. So going in there and deleting results after the fact is actually very difficult for medical legal reasons. And so you can imagine in a world in which we live now where clinical colleagues immediately see everything that's in PACS, they could be making a decision based on an incorrect AI result that was sent to PACS, while I'm, as a radiologist, figuring out that this is in fact an incorrect result. I have no idea that someone is already making a decision of that. This is all real time in these days in our digital specialty. So I'm very reluctant. So we stage it. Currently, we're not sending anything to PACS, but I can see in the near future that we will be releasing validated results to PACS because some of the more quantitative AI outputs are valuable for clinicians to see in PACS. But I would recommend to any and all of you that are in this business to very, very carefully think about what you're sending into the record and really keep an eye on that.
Mm-hmm. Absolutely. So I guess just thinking about the value of AI, and there's an awful lot of applications out there, but equally interesting are the applications that aren't out there yet. And thinking about what are the next areas which are unexplored so far for AI, but what would a radiologist suggest that you go and look at, and is the radiologist the right person to ask about that?
Well, yes and no. No, because like anyone else, we have tunnel vision. A tunnel vision that comes from probably mainly two sources. One is we are clearly used to practicing the way that we're practicing now, and it is always difficult for any practitioner of anything, or even for a tradesman, to imagine doing things completely differently than how they were trained. So naturally, we all have tunnel vision. We are also clearly, most of us, there are some notable exceptions, but I certainly fall into this category. Most of us are not data scientists. We're not trained in the use of and all the ins and outs and sort of intricacies of this new technology. So there's a lot of learning that has to occur for us clinical radiologists to really understand the technology itself and what it can do, its promises, to then begin to understand what could be done in the future. I think one particular thing that radiologists have a hard time wrapping their brain around is scale, or what can happen at scale. I'll give you an example. We're so transactional, we're so focused on applying the interpretation of an imaging exam to an individual patient context, and sort of we also think about whether it's valuable or not in that context. So if I asked a radiologist, do you think it's valuable if an AI can tell you how much of the lung is involved with COVID in a patient who has COVID? Probably most radiologists would shrug their shoulder and say, yeah, you know, I can do that. I can say it's mild, moderate, severe, or I can think of a score. There are scoring systems, but that's not a difficult task for someone who's used to looking at chest X-rays. So they might think that this is not of terribly much value. Let's take the scale perspective. What if you're a health system that is managing several thousands of beds across multiple institutions? You have an influx of COVID patients in one more than in the other, and you only have a limited number of ventilators. And your challenge is to move your resources around, your ventilators, your people, or possibly transfer patients. Now, having a computer tell you for every patient in your entire health system who's got COVID, who got a chest X-ray, how severe the disease is on a daily basis, day after day after day after day, in a way that you can compare, because it's a numerical score, is extremely valuable. So at scale, you know, the computational assessment of the seemingly simple radiologist task, at scale, it can only be done with AI, and it becomes extremely valuable. Now, how would the individual radiologist whom I asked the question in the first place know that? They wouldn't. It's just not the way they think. It's not their job to do that. So you could. This is a very exciting field. You could see how aggregation of AI results at scale, can become a whole new field. Can be extremely valuable. Similarly, with enterprise enterprise operational informatics, results about our operations, how we function, again at scale. There's tremendous value to unlocking that data. So scale is not something that comes easy to individual tradesmen and practitioners.
Absolutely. Yeah, and I think that that example of how do we see the downstream impact, and maybe, I suppose it's the ultimate outcome if you need a ventilator, having one available, right? But the financial impact for a large health system, being able to appropriately move resource around to solve massive problems, really has a fundamental impact on the quadruple aim, right? Where we're kind of going full circle in our conversation and looking back to that top level picture, that a measurement that a radiologist could do in their sleep, but might not actually record in the report in a way that can be used at scale. I guess, is this radiomics? Is this the general term? Am I right there? Or
yeah, I think radiomics would be an image-derived integer, or a number or a piece of information that could then be utilized.
that would be shared, but wouldn't today be shared. Yeah, I mean, I think we see things with multiple sclerosis quantification, with dementia quantification, all sorts of areas like that. And again, just trying to think of where the downstream value lies, be it population health, be it resource allocation, be it scheduling. It's a fantastically interesting area.
Yeah, that radiographics article that I cited earlier by Perry Pickard is exactly that. You essentially take an abdominal CT scan, you run a caboodle of AIs, out comes a complex radiomics profile of a patient. You know, it's already going into the, I don't know whether you're familiar with the concept of a digital twin, but you're basically building a digital representation of a human, which is very specific to that patient. Combining that with some clinical parameters, you can now do very specific disease risk quantification, prediction of the likelihood of certain adverse events, and then knowing that individual risk profile, which is derived from these multidimensional radiomics, you can then actually modify how you treat that patient. So I think that's and that can be scaled because you can do that for everybody following the same principles. So that would probably be a good example for multidimensional radiomics.
Fantastic. Well, I mean, I think Alexis has mentioned that we've only got a couple of minutes left, but thank you ever so much for taking the time to have the conversation, and really very interesting topics.
Yeah, thank you so much, Ben. I love chatting with you, and I enjoyed the opportunity to share some thoughts here in this webinar.
Great.
And just to echo the thanks on behalf of AIMed, Ben, Christoph, thanks so much for a really excellent session and conversation. We covered a lot of ground there. We really appreciate it. As mentioned, though, that is all we have time for today. So thanks again so much, gentlemen, for your participation today, and to everybody for joining us as well. This session will also be available on demand on our website, ai-med.io. For now, I've been Alexis May for AIMed. Look forward to welcoming you to our next AIMed live webinar, and best wishes for a lovely weekend wherever you are. Thanks again. Goodbye.
Thank you.